This video will discuss how to use our MPI data to trace contacts of patients and who they're connected to, tied in with the lab results from COVID-19, so we can give our frontline healthcare workers an alert that a patient might be a carrier, even though the patient might not know it yet. We will introduce the concept of modern search that helps to do the contact tracing by matching patient records more effectively, even with very dirty MPI data. The critical piece is making sure we have all available capabilities to slow the spread of COVID-19. This video will be a short introduction to using modern search to slow the spread of COVID-19. This video is brought to you by Medarcus, a healthcare product and services company featuring patent-pending matching technology, data integrity tools, MPI cleanup software, contact tracing, demographic and clinical search tools, and population health solutions. COVID-19 seems to be with us for longer than originally anticipated, and it's still spreading in the United States as of June 2020. We need to slow the spread of COVID-19 and apply the lessons learned to any infectious diseases that hit our communities in the future. We do this to protect our patient populations and our frontline healthcare workers. COVID-19 is an especially contagious infectious disease. It is insidious in that the carriers can go days or sometimes never even know that they are infected with the virus, yet they still infect others. And COVID is unlike Ebola, for example, where Ebola is so deadly that it often kills the carrier before others are infected. COVID is just the opposite. It infects many before the patient even realizes that they might be sick. Back in March of 2020, Iceland did an aggressive test for the entire country, and studies of the Iceland test show that approximately 50% of the COVID-positive patients were asymptomatic. The asymptomatic nature of COVID leads us as technologists to use atypical solutions to identify patients. We have to fight fire with fire. And given this characteristic of COVID-19, we must treat every person as a risk. Hence our social distancing, our masks, and the general economic shutdown that's happening in the US and abroad. But what if we knew that a specific person, presenting patient, was a higher risk of carrying the virus than others? We would want to know this, right? We will discuss how modern search technologies can be leveraged to do contact tracing to give us an early warning for possible COVID-carrying patients. And with many similar patients in the MPI, and with so many errors in the MPI, there's no wonder that it's hard to find the correct patient. Failure to find patients causes duplicate and overlay records, and this explodes our risk of exposure to COVID-19 when our patient search mechanisms do not work as well as they could. In fact, we have a 1 out of 12.5 chance of selecting a duplicate record, with an industry average 8% duplicate data rate. And from my experience, I've seen duplicate rates much higher than 8%. With a 12% duplicate rate, our chances of finding a record that is part of a duplicate rises to 1 out of 8.3. And if your MPI has not been cleaned recently, the odds will increase even more of finding duplicate records. The reason is because EHR search misses 30 to 90% of duplicate data. This is according to a National Patient Identity Misidentification Survey done in 2016. The top 3 leading causes of death in America are heart disease, cancer, and medical error. Johns Hopkins University did a study where they estimated 250,000 patients per year died due to medical errors. Some of those medical errors were due to data errors that caused patient misidentification. Those patient misidentification errors are directly due to errors in the MPI and EHR searches not working well enough to find the right patient. The failure of EHR searches puts all of us at great risk in times with COVID-19 or other infectious diseases. If we happen to pick one half of the duplicate record and get the wrong half, that is, the half of the record without the positive COVID-19 lab results, our frontline healthcare workers are at increased risk when we are working blind without knowing a patient's exposure. Even in clean MPIs, there's a strong possibility of picking a duplicate record. And in today's environment, this is a big gamble to me. It's a matter of life and death, and it's not a risk most of us want to take. The MPI searches on systems with bad data reminds me of an old saying, garbage in, garbage out. And it's hard to find patients when our MPI data is bad and full of errors. Because EHR searches fail often due to underlying errors in the MPIs themselves, or when users using the EHR mistype what they're searching for. The searches fail. So if the match is not exact in the MPI or what you type in, and the search information doesn't match perfectly, the EHR search will not produce results. It fails. This is because EHR search assumes perfect data. It's text only, and that's a huge limitation and the reason for all of our duplicates in the EHRs. EHR search misses the mark. All of these small errors in the EHRs contribute to search failures, and there's nothing that this older technology can do to find the records when the data doesn't match. Often we don't even find patients with the data we're typing, or we only find part of a duplicate record. Or worse, we have overlay records where we have the wrong patient and we put information into that record that does not belong to her. This is also a HIPAA violation. There's an old saying, death by 1,000 cuts. Every misspelling, every address error, every piece of information that's missing all contribute to high duplicate rates, or worse, overlay. It's death by 1,000 cuts. And no MPI, as a result, will ever be error-free. Humans schedule appointments, register patients, lab techs enter results, technologists merge MPIs. In other words, errors are introduced in the MPI at every step of the data lifecycle. And that's the big epiphany we have to have. is that these errors are created by humans, by us. To forgive is divine, to complete the quote from Alexander Pope's famous poem. And to do this, we must accept that we're always going to have bad data in our MPIs. Our MPIs will have many data errors. Our MPIs will have many duplicates and overlay records, unfortunately. And that has to bring us to the conclusion that our search, our patient search, must work with imperfect data. But the problem is, our underlying EHR search technology is very old, often from the 1960s, 70s, and 80s, and the technology does not fit the reality of our situation in healthcare today. The question becomes, if EHR search is so old, what can replace it? The requirements must be that the search has to be fault tolerant because of the errors in the MPIs, and the technology has to be flexible so we can not only match patients with data errors, but we can do other functions within the hospital, such as contact tracing in circumstances like the COVID-19 infection today. Let me explain what modern search technology is so we can move forward. Let's first consider, where do we find powerful and easy to use search now? Well, let's consider the web, for example. Our MPI data is much smaller and much simpler than all of the internet. And often our search subject is right in front of us. Yet we still cannot find all of their data in the MPI, but when we go on the web, with its billions of pages, we can locate what we're looking for. For example, I'm looking up a song by Adelaide and I misspell her name, and I'm just looking for the lyrics, but I find many examples of data that's related to Adelaide's song. Videos, reviews, lyrics, and this is exactly analogous to searching for patient data in our EHR. So let's connect the dots for the inspiration for modern search. Our medical data is full of errors. The internet search technology works well with data errors. This should be a rhetorical question, but what should we use to search medical data? The answer, of course, is internet technology. These new search technologies and techniques are very powerful because they're math, not text, and we match with patterns. And to make sure search works, we assume bad data, not perfect data like EHRs assume, but modern search presumes the data has many errors and uses the appropriate technology to still find the results. This is critical in times of COVID-19. Modern search technologies are fault tolerant because they consider the records as mathematically similar, not exact text matches. That is the distinction that makes internet search work really well, EHR search work not so well. Modern versus old. The technology works because we're looking at pattern matching techniques. We convert medical records that used to be searched with text. Now we search with math and patterns. And you can visualize these medical record profiles as histograms as we try to visually match them together. Show me the records that look like what we're looking for. We're looking for profiles simply that look similar. And this looking for similarity is what creates the powerful fault tolerance that we are accustomed to with internet search. This pattern matching for noisy data is applicable across many healthcare problems, such as contact tracing for tracking infectious disease spread. And as we apply this pattern matching capabilities, this allows us to match on very, very bad data. And I'll give you an example. If we're trying to match this patient name, Janet Montague, and we make many, many modifications to the data over time, first and last name reversed, errors in the names, address fields, social security numbers, telephone numbers, city and state, etc., a pattern matching system still has a very good chance to find that patient, even with all of these errors. And this is critical when we're building contact tracers, looking for the potential spread of infectious diseases. So properly set up, modern search can be fault tolerant enough to find patterns in very dirty MPI data, yet still produce matches. And as part of the search, we will normalize the input information to make it match what is normalized inside of the database. Normalizing data creates uniformity in the data, so it's easier to match. We capitalize letters. We update the text to common abbreviations, correct errors, and standardize everywhere we can, removing punctuation, etc. Normalizing data makes any search, including modern search, work significantly better. And when we're trying to find patients, all patient records that belong to every patient, normalizing data is a huge assist in that endeavor. For MPI data and contact tracing in particular as it relates to COVID, we focus on normalizing names and addresses so they match more effectively. Most importantly, we're looking at the home and work address for comparisons. And we also convert the address to latitude and longitude numbers so we can measure the distance, how far the patients are away from those that have been proven to be positive for COVID. When we normalize addresses, we do this to the U.S. Postal Standard. What we're trying to understand are where do our patients go and who do they know? It is suggested that we pay special attention to normalizing names because sometimes patients are registered under given names and other times the same patient is registered under nicknames. We also have to be aware of the phonetics. When names sound alike, Jim, J-I-M, is not the same as Jim, G-Y-M. The same thing goes for Jeffrey with the G and Jeffrey with the J. Even more tricky are non-English names, particularly those languages that are tonal. For example, Chinese. The name Xia often appears in MPIs as She, S-H-E. The X and the S sound the same. However, most phonetic algorithms do not take into account the language of origin of the name when the phonetic translations occur. The modern search capability with the normalized names and addresses produce a very good system that allow us to track patients and the spread of COVID-19. The risk score that we develop can only use the data we have available to us, our EHRs, our labs. We use HL7 technology to link everything together with a modern search capability. And then we can apply some science, social science and mathematics, and computer science to build networks of patients so we can analyze how they're linked together. Once we have that information and we score the patient's risk for COVID-19 exposure, then we can also update our workflows in our EHR systems so notifications of risk are available when we need it. Specifically, we're going to build a connectivity network from patient data. We're going to connect our lab work to that network. And then from that information, we will score each patient's risk for exposure to COVID and ultimately present that information to the healthcare workers. Let's consider the social science theory of 6 degrees of separation. It was popularized by Kevin Bacon in the late 80s, early 90s, I believe. But it's a psychological social theory that says we are no more than 6 degrees of separation from anyone in the world. To illustrate this, let's see how far we are from the Dalai Lama. We, us, but I know a friend, Lee, who used to work in the Clinton administration, and Bill Clinton obviously has met Dalai Lama. So that means we are 1, 2, 3 steps away from the Dalai Lama. The flip side of this, it also means that COVID-19 is much closer to us than we probably realize. But not knowing is dangerous, especially because a lot of patients, as we discussed earlier, are asymptomatic. So they do not even know that they have an exposure risk and possibly are carriers. So the first step to creating our network to look for exposure risk is building a family tree from our EHR data. We used the clean address and name fields we did earlier, and we look for common surnames, common addresses, common shared relationships, common next of kin, common guarantors, and we can infer a family tree from this data. Now, we do need to confirm these relationships with patients using HIPAA-compliant questions, of course. But as we confirm each patient relationship, we can strengthen the ties in our networking model to reinforce the possibility of diseases spreading as family members happen to congregate. What we're really looking for are who the patient may have come in contact with. Family members are one class of people, but also our coworkers and those in our general surroundings. We will use modern search techniques to compare addresses and locations to see how the patient may have crossed paths with others that might be infected. To do this, we're only going to go 3 degrees of connectivity. We could go deeper, but we believe 3 degrees is sufficient. Once we have built our network from those we are related to, those we are potentially related to, those that we work with, those that live in the same apartment building we live in, and so forth, we add the lab work to each patient to this newly created network. We mark those patients who have tested positive for COVID-19 with red. For those that have tested, but we do not have results yet, we mark in yellow. And we do this for the entire network related to the patient until we finally get to the stage when we can score the patient risk. We suggest a model called the Proxer 3D, which is just a methodology to assign risk to a patient based on how the patient is connected to others that might have the disease. We score the patient network, 10 for those that have the disease, 2.8 for those that are testing, ultimately, and create a weighted score based on the patient's connectivity to those that have the disease or are waiting results. We use the rate of infection of the disease, called R0, to help us percolate the scores through our network model. R0 is the number of patients on average that are infected from others. We are doing all this work behind the scenes Ultimately, so we can alert the healthcare worker to his or her risk when dealing with a presenting patient. And the very last thing we do is to update our search results, whether it's driven by modern search or your EHR search directly. Every time a patient is looked up, we should present the Proxer 3D score to those that need to know. This is a measure of the patient's risk of exposing the healthcare worker to COVID. I hope this video helped present an idea to slow down COVID-19 by improving our patient search to such a level that we can use it to build contact tracers from the data that we have available, our MPI data. By leveraging where patients live, where they work, who they are related to, who they may come in contact with from all this data, and marrying that information up with COVID-19 test results in our lab work, we can build a reasonable network model going back to the 6 degrees of separation theory to see how the disease may spread through our network. And using a scoring methodology, we use Proxer 3D, but you may use any methodology. By scoring the risk for each patient and alerting the healthcare workers in their normal workflow process, we can effectively reduce the spread of COVID by letting patients know and our healthcare workers know that they are at risk of being a carrier because of who is in their network. Knowing which patients present higher risk to us is a valuable piece of data to know. I hope that's helpful. If you have any questions at all on modern search, how to build a contact tracer from modern search, how to use any of the techniques we talked about today, please do not hesitate to email at info@medarcus.com or connect with us on any one of the social media networks, LinkedIn, Facebook, Instagram, or Twitter, and we will be happy to answer your questions and give you some guidance on how you might achieve these goals. Thank you so much for listening to this presentation. I hope this information was valuable, and have a great day. Thanks for listening.